Let's get started with this lecture, though. We've got anticoagulation today, which is every pharmacist's favorite topic. Yeah, it's kind of like our bread and butter. Clinical pharmacy, more or less, was invented around managing anticoagulation and managing antibiotics, and it's kind of spread out from there. So, I'm being kind of sarcastic that it's my favorite topic. It's not my favorite topic, but it's not a bad topic. It's just something that every pharmacist has to be able to do. So it's something that we all kind of know pretty well. Okay, so talking about clots, we're going to talk about antiplatelets and anticoagulants as they are different. And talking about the difference between them and the different mechanisms of action we can try and manipulate in order to prevent a clot from forming or prevent the body from clotting as well as it normally would. So the very simple way to break it down, red clots and white clots. Red clots are rich in blood, fibrin. Think about blood pooling or hemostasis events in the body. So think about like DVTs in the extremity. That would be an example of a red clot. White clots would be platelet rich. It's usually going to be more arterial related, so high flowing blood. It's going to be because there's probably some sort of a trauma to that vascular system. So the perfect example would be in the coronary arteries. You have plaque rupture, platelets start to aggregate, you get a blockage in that artery. Most thrombi will end up having components of both. So if you think about like the white clot, if platelets get recruited and start clumping together, you end up with hemostasis in that area as well, which causes a red clot. So usually you end up with both, but we do target different things. So for example, if you go back to the acute coronary lectures we talked about last week, there's not really any indications for using an anticoagulant, except maybe sometimes in the acute phases. Long term, we just use antiplatelet therapy because you don't really have to worry about anticoagulating somebody and having a rebound cardiovascular event like an ischemic heart attack. Whereas with something like a deep vein thrombosis or a pulmonary embolism, that's exactly what you're concerned about. You don't really care about the platelet component as much because it's more about the blood pooling in the extremities, or like in atrial fibrillation, the blood pooling in the ventricle or the atria of the heart. So those are where we're targeting, and we're going to talk about both today in a little bit more detail. Here's just a drawing to talk about what I just said. All right, platelet biology. So platelets have a bunch of different ways that they link up together and recruit each other. So basically, that's what we're going to talk about as far as drugs go. One thing to remember is that platelets have about a 5-day life cycle. So if you're inhibiting a platelet's ability to clot, it takes 5 days for your body to make a new platelet to replace that one. That's important if you ever go into like surgical practice. I mean, it's going to be kind of a standard of care where if you have somebody on aspirin, you're going to have them stop at like 7 days just to be safe before surgery. Or let's say you had, I'm trying to think of another good example. That's probably the best one I can think of. I'm not going to go into any other weird details. But yeah, post-procedure, that's pretty common. So if you end up working for a surgical group, that's something you'll be telling a lot of your patients to do. So anyway, the platelets have all these different mechanisms on them. Fibrinogen links up with these different receptors. So we have drugs that can interact with the GP2B3A receptors. We have drugs that do things intraplatelet as well and prevent like ADP, this process from taking place. And there's some other things to talk about too, but that's pretty much it. All right, so the two main drugs we're most concerned about are aspirin, which is a thromboxane A2 produced via the cyclooxygenase pathway. We already talked about this a little bit, but that will block platelets from, if you inhibit that process, you prevent platelets from clotting, and you can do that with very low doses of aspirin. The P2Y12 inhibitors, or the ADP inhibitors, prevent interaction of ADP with G protein coupled ADP receptors. And then GP3A3B inhibitors are not something we're going to talk about a whole lot. I mentioned them briefly during the ACS stuff, but I don't really want to go into many details on them. I'm not going to test you on them. They're really acutely used in like cath lab procedures and nowhere else. So they have a very niche role. And even amongst like people undergoing PCI, I think it's like 10% get one of those drugs. So it's an odd, well, not a common situation that you're going to be in. I don't think it's really worth talking about them too much. There's some other things out there too. Cyclic AMP interference. There's a drug called dipyrimidine, which interferes with platelets' ability to aggregate. That's not indicated for any cardiovascular. Well, not indicated for any post-MI type indication, like we've already talked about. It does have some stroke-related indications, so we'll come back to that during neuro next spring. And then there's some new drugs out there that they looked at, like a thrombin antagonist, to see if you could directly antagonize thrombin receptors, and found not to be beneficial and increase bleeding in patients. So we don't really have any other options other than our really old standard aspirin, and then the P2Y12 inhibitors, which have been around for quite a while as well. Not quite to the aspirin level, but definitely clopidogrel's been around for probably a couple decades now. So this just shows another the diagram in a little bit more simplistic terms with nice circles and arrows and things like that. So platelets activate, and again, there's a lot of different ways they can do this. So it's very difficult to interrupt the entire platelet cycle with one drug. So sometimes that's why we do two drugs, or you just assume that certain conditions are okay with a single agent, and that's where we might just recommend aspirin alone or something like that. But for most MIs, that's what we're going to be looking at, is aspirin plus Plavix. You get the dual mechanism there, and that way you should be able to inhibit quite a bit of platelet activation that way. Yes, you increase your bleeding risk, and that's the whole problem with anticoagulating somebody in general, right? If you inhibit their platelet activity and if you anticoagulate them, they will bleed if they get cut, they will bleed if they get into a traumatic accident, and that's dangerous, of course, especially if they fall and hit their head. So we're always concerned about that. It's just sort of, that's why these medications are considered higher risk. If you look at stratifications of, what groups of patients present to the emergency department due to adverse drug events, the majority of them are going to be either due to anticoagulation related issues, so they're bleeding out somewhere, GI bleed, head bleed, something like that, or it's going to be hypoglycemic because they took too much insulin or something like that. Those are the two major drug classes that lead to a lot of chronic medication use related emergency department visits. So yes, there's a lot of danger in doing this, but the mortality benefits generally outweigh the risks. Okay, so let's dive into aspirin a little bit more. We most always use aspirin as the 81 milligram or baby aspirin. If you're ever wondering why it's 81 milligrams, that's kind of an old dosing system that they used to use back before they standardized things, and they used to have grains as the unit, which was abbreviated GR, and so 81 milligrams is back to partial, like it's 2 grains, I think, is 81 milligrams or something like that. Anyway, a lot of European studies, or if you read studies out there, they'll have people on 100 milligrams of aspirin, which probably makes more sense. Sometimes they'll say, like, patient was on 100 milligrams or less of aspirin. So that includes people on 100, which is more the European dosing, or the 81 milligrams. So if you're ever like, why is there a 100 milligram aspirin dose, and why can't we get that in the US? It's just the way it's always been grandfathered in, and the way we've always dosed it. The term baby aspirin, a lot of people use it. It's kind of a bad term because we don't use aspirin in kids. In fact, it's contraindicated in children, but that's the way we call it. So it's a baby dose of aspirin is the way I like to think about it. 325 milligrams is the full strength aspirin. So that's what you'd see if you bought like the full strength Bayer or whatever you get over the counter. And usually the only role with this is loading in the acute phase. You can take aspirin for pain management too, and we'll talk about that next winter, well, in January sometime. But you have to take a lot of aspirin to really get a good pain effect, so it's not great. And the more aspirin you take, one of its side effects is it does cause some dyspepsia. So a lot of times it comes as an enteric-coated formulation, so it can get through the stomach a little bit easier and doesn't cause indigestion in people. But in the acute phase, you don't want that. You want them to be able to chew up a tablet really quick that's not coated so it gets absorbed fast, and we don't really care about your heartburn at that point, right? If you're having a heart attack, you probably have bigger things to worry about. So in the acute phase, usually they'll load somebody at 325. So if somebody's taken like an 81 milligram aspirin and they're on it daily and they come in having an acute coronary event, they're just going to QS them to that 325. So they'll give them 3 more baby aspirin, chewable tablets, chew them up. EMS keeps this stuff on their rigs in the ambulances, so it should be given before anyone gets to emergency department. A lot of people with chest pain who have any type of EKG changes, especially obviously ST elevation, right, but other things too potentially, they might just give that prophylactically. Certainly if they have ST elevation, they're going to get that right away. Aspirin has good bioavailability and absorbs pretty quickly. Good bioavailability and good peak concentration levels, and it works fairly fast, especially if you give a loading dose to somebody, even orally. So it's definitely indicated in the acute phase. And then ongoing therapy for most indications, 81 milligrams is fine. Sometimes they have the higher dose indicated For like cabbage, they might recommend the higher dose, but even then, sometimes people might use the lower dose depending on the risk of the patient for bleeding. Usually, you don't get a ton of benefit with higher doses. Again, with the antiplatelet component of it, you just get higher risk of bleeding and more side effects. There is a suppository available too, and the only reason I say that is you might have somebody who's unconscious or can't tolerate PO, and you can't get a feeding tube, or you can't get an NG tube down in time, and you can give it rectally. It does have good bioavailability that way. So like our MI kits have an aspirin suppository in it. Gosh, I can't think of the time I've used it, maybe once or twice in my career. Yeah.
What is cabbage?
Coronary arterial bypass graft. So like a bypass, when they say like triple bypass or double bypass. Yep. Inappropriate use. A lot of people think they should take aspirin just because it's over the counter and they saw a commercial or heard that prevents heart attacks or whatever. True technically in certain patient populations, but not for everybody. So a lot of people will take it without really any rhyme or reason. So it's a good thing to ask about. I always ask people about over-the-counter medications, and you'll be surprised what people tell you. If they do tell you they're taking aspirin, be like, well, do you have a reason why you're taking that? Did somebody recommend that, or why you're doing that? You're just putting that person at risk for possible bleeding in the future if they don't really need it. So there's been a lot of studies out there, and there's not a lot of evidence that shows that many age groups or patient populations really benefit from aspirin as primary prevention. It's mostly used for secondary prevention. So it means you've had an event and now you take aspirin. There are some indications. We'll talk about elderly patients, geriatrics, and maybe sometimes in diabetic patients and things like that. But for the most part, we use it as a secondary prevention tool. Continued aspirin stuff. So again, some people will say that if you're, I guess I'm going to go into this a little bit, over 50 and you have your 10-year like risk score above 10%, they might consider recommending it as a stroke prevention option. But again, that's a little bit controversial. The rest of the things we've talked about, status post-stroke, status post-ACS, aspirin is going to be indicated. Sometimes people who require anticoag, like AFib patients at low risk, talked about the CHADS VASC score. Again, side effects are there. We talked about that. Aspirin's really toxic in overdose if somebody takes a bunch of it, but usually that would be intentional in most cases. Not many people are going to, I guess, accidentally take aspirin in overdose. Children, I talked about being contraindicated in. There's a thing called Ray syndrome. We'll talk about that during pediatrics, so it's not really relevant to this because you don't really prescribe aspirin in children. Sometimes they do use really low-dose aspirin in kids, like who have congenital heart defects and they've undergone surgery. They might give them a short dose or short course of aspirin. It's, again, benefits outweighs risk. Ray syndrome is super rare. It's like has to do with viral illness and encephalopathy, and anyway, it's really rare, but basically there's no good reason to give kids aspirin in most cases. But again, getting kind of out of scope of this lecture here. All right, clopidogrel. Clopidogrel is brand name Plavix. It's the oldest P2Y12 inhibitor. It comes as both, all the P2Y12s have the availability of a loading dose and a maintenance dose. Clopidogrel, again, was the first one, so it was the one we used all the time because we didn't have any other options. And so it used to be this 300 to 600 milligram load, and then a 75 milligram once daily maintenance. I don't care any doses for this test, but just so you can kind of see what the difference is here. Prodrug. So this is an interesting prodrug. I think I used this as an example in the first lecture we had, which is probably long gone in your brains by now. But remember, prodrug is something that needs to be converted by the liver into its active form. And so for clopidogrel, if you have genetic polymorphisms that diminish your ability to metabolize things via CYP2C19 or 3A4, then you might not get the full benefit of Plavix. So genetic testing is actually pretty common when it comes to clopidogrel, and up to 30% of patients it might be ineffective in. So that's a pretty standard thing that they'll do is test which liver enzymes function correctly there and make sure that you're going to be able to metabolize it to the active form. If you can't metabolize it to the active form, drug's not going to do you a whole lot of good. There is some drug interactions too to consider, usually not substantial things. There was this big scare a while ago where proton pump inhibitors all have like different mechanisms of inhibiting CYP processes, and they're super common. So a lot of people take Prilosec, Protonix Nexium as an antacid agent, and we found there was some study that came out that said that it was diminishing the bioavailability of the end product, the active drug of Plavix, by like almost 60% or something like that. So people are like, well, is this a big problem? Are people going to have increased events because they're taking these things combined? So everybody stopped their patients on any proton pump inhibitor and started different medications for heartburn. And then they did more studies and found that it didn't really matter. So that's kind of phased out. But people get really nervous about Plavix and drug interactions just because it is a pretty big deal if you have another blockage in your artery and have a heart attack, because that's, if you don't get to a cath lab in time or something, high mortality. So we certainly want to take it seriously, but they just didn't find that you needed that high of level of Plavix, I guess, so that drug interaction could take place and everything was still pretty good from a therapeutic benefit. So Plavix is generic. It's been generic a while. It's relatively affordable. So the reason why I talk a lot about Plavix is the vast majority of people, assuming they don't have a genetic polymorphism, they're going to be on Plavix as their long-term agent just because it's cheap. We know how it works. We've used it for a long period of time. We trust Plavix. So clopidogrel is going to be the drug of choice for maintenance. Now, loading-wise, it's sort of fallen out of favor, and there's been some studies to back that up as well. All right, second drug, prasugrel or Effient. Prasugrel is, again, load and a maintenance dose here. Prasugrel has some dose restrictions. If you're over 75 or under 60, you're supposed to dose restrict down to 5 milligrams a day instead of 10. It's also a prodrug, but it has a bunch of different CYP pathways. So if you have one polymorphism for one or two enzymes, it's probably not going to be a big deal. Most people don't care, and they'll use prasugrel as an alternative to Plavix if you do have polymorphisms. It's the longest lasting of the P2Y12s. It has a lot of active metabolites. Therefore, it also has the highest bleeding risk. And it's contraindicated if you have a history of stroke or TIA, as it's shown to form. People have had risks of converting from like an old ischemic event into a hemorrhagic stroke with this drug, so we don't use it anymore in those patients specifically. These P2Y12s have a big role in stroke prevention too, and again, we'll come back to that next spring. But the one thing that's come out, there's actually a study that just got published in New England Journal about P2Y12 inhibitors, and it was looking at prasugrel versus ticagrelor long-term. It didn't compare prasugrel versus Plavix, which is a little bit unfortunate, but it basically said that prasugrel's bleeding risk wasn't that bad at all. So maybe long-term we will see more prasugrel. I'm not entirely sure how that's going to shake out again. It's a pretty new trial, but they compared it head-to-head against ticagrelor, both giving people one or the other in the acute phase and then for maintenance therapy, and followed them for a year. And actually, the prasugrel group did statistically better in every outcome for all-cause mortality, less strokes, less trips to the cath lab again, and overall slightly lower bleeding risk even in the prasugrel group. Now, does that mean it's better than Plavix for a maintenance drug? I don't know. That's a good question. We aren't there yet. But it's interesting because ticagrelor is the newest agent, came on the market, I don't know, maybe 6-7 years ago, maybe a little longer than that. But it's got a loading dose and a maintenance dose, as you can see there, just like the other one. It's a little bit different. It's not a prodrug, and it has reversible binding. It has really high percentages of platelet inhibition, and it works really quickly. So it's kind of become the mainstay for your acute phase. And there's a lot of good data that says that people who get ticagrelor versus clopidogrel in the acute phase of an ACS event are going to do better than, again, the ticagrelor people are going to do better than the clopidogrel people over time. Now, this interesting study came out and said, well, what if we continued ticagrelor for a year and compared them to somebody continuing prasugrel for a year, and they showed that ticagrelor people had more bleeding and poorer long-term outcomes. However, in practice, generally don't give people ticagrelor long-term. It's really quite rare to do that, just because the other ones are once daily, so they're going to be more convenient and compliant with that. And it's a little bit more expensive. It's one of the newer ones, and so it's got some costs associated with it too. Again, primary drug for acute, not really preferred for maintenance. And as far as maintenance, clopidogrel is still, despite the new evidence I've been talking about, clopidogrel is still preferred, and prasugrel is kind of the backup for if you had somebody with a polymorphism that you could identify. Now, in the future, are they going to change to maybe match some of this new data? I think there'll probably have to be more trials and things like that. But it was a big trial. It was well done. So it might change in the future, but right now we're still kind of status quo. All right. Yeah.
Can you explain what a load dose is?
Yeah, so that'd be just like if you come into the hospital and you're having a STEMI or an NSTEMI or even unstable angina and they've identified a blockage, they're going to give you that right away. So you're just going to take that basically as soon as you walk in the door. It works really quickly, and then so like if you have somebody comes in the ambulance and they've identified it as a STEMI, they will give you that as soon as you can, and then they get you to the cath lab. So it's basically the fastest onset one, and so that's why they load it that way. And that was the intention with Plavix too, when it came out, that they would load Plavix in those acute phases to get enough on board that it would help. And you can still do that with Plavix. And that would be fine if you're going to send them to the cath lab later. Like if, let's say they come in with an NSTEMI, they're doing okay, and the cardiologist says, well, we don't really need to do it tonight. Let's schedule them in tomorrow. We could do that, and then you could do the Plavix load that evening, and then they'll be inhibited by the next day. But ticagrelor is the preferred for just because it's faster. So it depends on risk too, and STEMIs are always going to be higher risk, and we need to do this now versus an NSTEMI. This is just a chart that shows the comparisons of all of them. I don't really want you to know much more than what I've talked about already. I'm not going to ask you a ton of questions about the differences. I would like you to know that generally the evidence does show prasugrel has more bleeding risk and does have some more contraindications, and that we prefer ticagrelor in the acute phase and clopidogrel for maintenance, and then knowing the general mechanism and what they do, that they're antiplatelet agents. The rest of this is a little... yeah, I don't really care, how much you hold it for or anything like that. But there is kind of an interesting thing with ticagrelor that I'll just point out. It's contraindicated for aspirin doses more than 100 milligrams due to bleeding risk. So it is a little bit of a more potent agent that way.
For the acute MI type situation, I haven't seen ticagrelor or whatever it is recommended for that initial treatment, like anticoagulation or aspirin. Is that just?
It should be given alongside of those two, yeah. So.
Is that in every setting, like in an ED or an ambulance, or?
Ambulances usually don't have ticagrelor. They won't have anything. Yeah, it's kind of too expensive for them to keep, and not all hospitals will do it, but it's like our standard at Alina. Abbott probably has the biggest cath lab, and well, maybe not bigger than Mayo's, but yeah, it's our standard of care. Anyone who comes in with a STEMI is going to get ticagrelor.
It's not on current guidelines, but will be sooner or fewer.
I believe loading doses should be in our current guidelines, so you should load with a P2Y12. They might not specifically recommend one over the other, though, but evidence would say that, based on studies that are out there, ticagrelor patients have better outcomes if you load them with that versus clopidogrel. So, yeah, a lot of the guidelines might just stick to load with a P2Y12 plus aspirin as sort of a generic recommendation, but yeah, you have to look at the other pools of evidence out there. But yeah, they might update it eventually to do that, or they might decide, well, we're okay with centers doing whatever they want based on what they feel like is fair for them cost-wise or whatever too. If you want to read the trial that compared ticagrelor to Plavix, the Plato trial was a big one. That was a New England trial that came out a few years ago, in case you want to look at that more. All right, switching gears. You guys good on antiplatelets? All right. Clotting cascade, you guys have seen this before in your lives at some point, am I right? Okay. I think everybody's seen this at some point. I don't really care, a whole lot about the clotting cascade with the exception of two major points, and that's going to be within the common pathways. If we need an effective anticoagulant, it has to do one of two things. It has to block factor 10, 10A to be more specific, or factor 2. That has to be included with all of our anticoagulants. Everything else is a little bit, so if I say like Warfarin blocks factors 5 and 7 too, it's like, whoop-de-doo. We care about 10 or care about 2. Those are going to be, again, that common pathway is going to be the most effective bang for your buck when it comes to anticoagulation. All right, so we're targeting the red clots here, medications, again, targeting that common pathway. There's a lot of different products available, so compared to platelet agents, this is probably going to sound a little bit more confusing and be more new drugs, but it's super important because so many patients take anticoagulants. We have fast-acting, short-acting, we have, sorry, those are the same thing. We have fast-acting, or I should say long-acting and short-acting, sorry. So there's like things you can give that work really quickly, like heparin. IV heparin works really fast. Or you could give something oral that might take a couple hours to be absorbed. Or you can give Warfarin, which takes a few days to start working. So there's a lot of variance in there. There's a lot of different ways we can give anticoagulants: oral, IV, sub-Q, multiple different pathways depending on what access the patient has and what indications they have as well. There's a lot of different anticoagulation indications out there. Generally, we're preventing clots from forming, so atrial fibrillation patients and VTE patients, so post-PE, post-DVT, those are going to be your primary group of patients and make up the majority of people. Sometimes stroke or acute coronary syndrome patients might be on an anticoagulation regimen, but that would be because probably they have something else going on too. So maybe they have atrial fibrillation and they had a stroke because of it. So it's usually goes back to these things. Generally speaking, just stroke patients alone aren't going to be anticoagulated if they don't have another reason why they have the stroke. Status post orthopedic surgery. Sometimes they'll do anticoagulation. Sometimes ortho groups will just do like twice daily aspirin. So there's actually some evidence where they do high dose aspirin regimens for a couple months post hip or knee replacement, and that does a good job in and of itself, interestingly enough, which doesn't really make a whole lot of sense based on what we've been talking about, but that's what they found out. And then just general prophylaxis. There's a lot of different reasons why you might want to prophylax somebody and prevent their clotting system. Sometimes there's oncology-related indications. There's a number of things out there that could apply. But again, the vast majority of things we're going to talk about are going to be VTE and AFib patients in that context. Monitoring. Anticoagulation requires a lot of monitoring because, as I just said, if you get too anticoagulated, you're at much higher risk for a bleed. So we want to keep you anticoagulated enough where we're giving you a therapeutic benefit from it, but not push you into the point where you're bleeding to an excessive amount. So that's where lab values come into play, and that's where there's a lot of differences in the different medications we have out there. So let's start with heparin. Heparin, you might hear heparin referred to as unfractionated heparin. It's the same thing. What heparin does is it potentiates antithrombin, which complexes with factor 10A, prevents the formation of thrombin. So you're working on that common pathway there. It also inactivates factors 9 and 10 and prevents the formation of fibrin too. So heparin's a very potent anticoagulant. It has a great role in acute care. Outpatient use is not great. There's not a whole lot of reason to give it, but we'll talk about that here in a second. It's really the standard of therapy for any type of acute care anticoagulation because it just works really fast. It's really easy to monitor. It doesn't last in the body too long. Its half-life is 1 to 2 hours. So if you do overdo the heparin or the patient responds in a negative way, you can stop the heparin infusion and you've only got a couple hours of anticoagulation until it's gone out of their system. Effects are basically immediate if you give it IV, which is another really helpful thing. Renal adjustment is not needed either, so for our renally impaired patients, that's a big benefit there. Let's see. Sub-Q or IV, so there's no oral form of heparin out there, and usually for sub-Q, you could give a therapeutic dose sub-Q technically, but you have to give a ton of heparin to get it to absorb subcutaneously. It's not a very reliable system. So usually what we see sub-Q done is like a low dose of heparin 2 or 3 times a day is the common way that we do. So we do 5,000 units, just doesn't mean anything to you, but 2 or 3 times daily is a fixed dose for prophylaxis. So this would be somebody who's like immobile in the hospital. They don't really have any risk factors other than that. It's not like we're trying to treat an active clot. We just want to make sure they don't get a DVT while they're in the hospital, or maybe in the nursing home. They do stuff like that too, but they'd have to be on a have a good reason for that. And that's a nice way to use heparin. Heparin, again, is quite cheap compared to anything else we're going to talk about within anticoagulation, and it works really well for that. But for standard treatment, if you're going to actually try and prevent an existing clot from growing larger, that's where you have to use an IV therapy usually. Sub-Q won't quite do it it could, but I don't recommend it. I'll put it that way. So heparin production is actually done by taking, it's a natural product if you want to look at it this way. They extract intestinal lining from pigs, process and fractionation, processing and fractionation, which basically gives you a product that they fractionate down until they can isolate the heparin specifically. There are synthetic and different ways of making heparin, but it's really expensive, and so the majority of heparin we get is porcine in origin. So it does have a pork origin behind it, which is sometimes causes issues, especially with Muslim population who will not adhere to pork, or other potential religious groups who have very strict pork. The most common one we see are our Somali population at Abbott, who will want something else, who will not want heparin for that reason. Now, just so you guys know, by the time I mean, it's a little bit, you're taking the heparin out of the pig, you're processing it multiple ways. It's not really pig product anymore, in my opinion. It's a molecule that they've really fractionated it down. But still, it's something that will come up occasionally. It does come up here and there. All right, IV infusion is generally, again, the way we're going to start. So let's say you come into the hospital, you have a really bad PE, you can't breathe, they're going to admit you, they're going to start you on heparin to make sure that PE doesn't get bigger. It's really important to note that anticoagulants don't break clots down, they just prevent them from growing larger so that your body can naturally clear the clot on its own. So usually with heparin, you don't really have to, the nice thing about being a provider, I think, in prescribing heparin, in my opinion, is you don't really have to do much with it. You order heparin protocol, and then your nurse basically takes care of everything for you, which is pretty cool. So we have a lot of weight-based dosing protocols. Generally speaking, this is kind of what you would get if you started somebody on heparin. It's going to be a standard unit per kilo loading dose. So you give somebody a bolus of heparin over 10 minutes. Then you follow with an infusion with a unit per kilo per hour. Looking to maintain what's called an APTT, which is partial thrombin time, activated thrombin time. Why am I blanking on what the P stands for? I think it's partial. What am I saying? Somebody knows? Maybe? Prothrombin. Thank you. Yes. Okay, that's right. All right. Okay. Okay. So here we go. So you have a couple different ways you can measure heparin too. Some sites might take that APTT and translate it to something else. So they might call it, like, we used to call them heparin levels at Abbott, which is kind of silly. That's not what. So basically they were taking it and converting it into another number, which, I don't know. Anyway, this person was in charge of anticoagulation for a long time within Alina, and she's gone, and so we're trying to fix all her weird things that she did. So anyway, it's basically a lab value that tells you how long your blood takes to clot. So the longer the time, the more effective the heparin. So if this gets outside of this range, above it, that's going to be problematic. So we want to try and keep it within that range. And again, heparin's pretty easy to titrate. You can give a little bit more. And it's all protocol driven. So what happens is the nurse will draw an APTT. They will plug that number in once it comes back from lab. The protocol that's built into our electronic medical system will tell them what dose to change their rate to. It'll say continue current rate, increase rate, down, or if it's really weird, it'll say call pharmacy, which is the least favorite option of mine. And then they say, what should I do? And you're like, I don't really know. Sometimes people are really resistant to heparin, so they might need a lot of heparin. Heparin's not, it's not like it's a slam dunk that that this dosing strategy that your protocol is based on will work for every patient. It's not a one-size-fits-all type thing. So you do have to monkey with heparin a little bit in the average patient. But most people will respond in a similar fashion. You do have those outlier patients, and you don't see that with all the many other anticoagulation medications, with the exception of warfarin. So anyway, you basically adjust the rate up a little bit, up or down, 10%, hold or rebolus if you need to. Protocols will vary by site and indication, but it's pretty much standard to have nursing run protocols managing heparin, so that's pretty common. And there's a lot of different protocols that might be within a site. So you might be able to order a high intensity protocol, you might be able to order a low intensity protocol or prophylactic protocol or a heart failure specific protocol. We've tried really hard over the last several years. I say our cardiology coordinator guy, Matt, has done a lot of good work over the last few years to condense those, because like our heart failure team didn't want 60 to 85 as the range. They wanted 70 to 86. Stupid things like that. It's like, really, come on guys, let's all be on the same team a little bit and make our lives easier, because it's really confusing, especially for nurses and everybody else, to have to run protocols when different groups want very subtle differences in the protocol. So anyway, you might see that different institutions where they have indication specific, but for the most part, therapeutic is therapeutic and prophylactic is prophylactic, and everything else is a little bit nonsense in my view. But that's all I'll say about that. All right, heparin, other than making you bleed, it doesn't have a ton of side effects. One of the ones to know about is something called HIT, or heparin-induced thrombocytopenia. It's noted by a precipitous drop in platelets about 5 to 19 days into heparin therapy. You stop heparin immediately, you don't re-challenge for another 100 days, and it actually increases your chance of clotting. So what this is the heparin complexes with platelets and actually causes a mass activation of a number of platelets, sort of an autoimmune response. Not autoimmune, sorry, immune system related reaction that occurs, and that reaction causes platelet activation. So you see the platelets drop, that's because they're all activating and they're getting all used up, and you can end up with ischemic events that look kind of like this. So it's definitely highly problematic. It's really, really rare, but it's something to note with heparin. If they do have a hit, you can try them on heparin again after that 100 days. It's thought that those antibodies will clear, and it's not proven whether or not people are likely to get hit again, but most people will take it, err on the side of caution and maybe prescribe something else if they're going to have to be anticoagulated again. So we have some other types of heparin too, called low molecular weight heparins. These are brand names enoxaparin and dalteparin. Enoxaparin is the one that's most often used. Similar to heparin, it's just basically like a heparin molecule that's smaller. So they take that heparin product that they isolated and washed out from the pig, and some drug company takes that and makes it into a slightly different molecule with some reactions to it. So it is technically a porcine product as well, but it's been modified even further. It does have much less incidence of HIT. However, it's not recommended as a HIT alternative. So let's say your patient develops HIT, you wouldn't switch them from heparin to one of these agents. You'd switch them to something else entirely, which I'll talk about here in a second. Basically, you're looking at factors 2 and 10. Again, the mechanism is fairly similar to heparin. It does a little bit different things, but not much. We usually don't have to do any monitoring with Lovenox or enoxaparin versus with heparin, we monitor basically every few hours. We're checking levels on them. With Lovenox, you can get levels on it to see, but it's a little bit confusing as to what you're supposed to actually do with those. Basically, the package insert dosing is what's recommended. So it's really simple. It's 1 mg per kg every 12 hours in most patients. There's some caveats there with renal function. If you have poor renal function, you can do a once daily, or you can do a diminished dose twice daily. It is a sub-Q injection, so patients need to be comfortable with that. It works about after 4 hours of injection too. So it's not a fast onset or a rapid onset like heparin would be. The most common place we see this used, I don't think I have this here. Oh, here it is. Yep. Is bridging therapy. So Warfarin, we'll talk about here in a couple slides, is kind of the gold standard long-term anticoagulant that's been around for decades and decades. Warfarin takes several days to work, and in the meantime, while warfarin's working, you're at risk for a clot. They bridge you with low molecular weight heparin. So you do Lovenox injections for 5-7 days until your warfarin starts to work, or you can measure the lab that tells you it's working, and then you usually stop it. That's pretty much, or you could bridge somebody off of warfarin too. So let's say you want to have somebody come in for a surgical procedure, and they're high enough risk where you don't want them to have too many days without anticoagulation. So you stop their warfarin a week before surgery, have them do enoxaparin until the night of surgery, stop it so that by the time they get in the next morning, 12 hours later, they have nothing in their system anymore. And that's, again, the kind of the reverse bridge there. And then you can bridge them back onto the warfarin after that if you want to. Venous thromboembolism treatment or prophylaxis, you can use this drug as a treatment option. It's just no one wants to inject themselves for years and years, especially if they have chronic recurring VTE, so it's really not a convenient option. But it is something that is used occasionally for that, depending on what other risk factors the patient might have. You can use a low-dose, low-molecular heparin too for prophylaxis as a once-daily injection. And again, that's kind of like the person who's immobile, who's at risk for a VTE occurrence, but isn't necessarily have any other overt indications for one. They just are, again, immobile in the hospital for whatever reason. Again, some of the cons: 4 hours to work, not a fast-acting option, not easily titratable. You can't change your dose. Once you've given somebody an injection, they're stuck with it. So if you overdo it, they're stuck being over-anticoagulated for 12 hours. It's not monitored, and I say that's kind of a good thing because your patient doesn't have to come in and get levels done while they're on this, but that's a little bit of a double-edged sword, right? Because we don't know how well it's working. We just assume that the package insert dosing is correct, and generally it is, but everyone metabolizes things a little differently. Not convenient. People hate injecting themselves. Unless they've been a long-term diabetic, they aren't going to be used to this. I used to do education on this. We don't really use these drugs anymore. We don't use bridging and warfarin anymore for acute VTE in our ED. We've mostly gone to some newer agents, which I'll talk about here in a second. But when I used to do it, I used to do a lot of education on this, and everyone I talked to would always have a big problem using needles, and it was frustrating. Just from me not being a provider, but me being the educator point of view, it's like talking to people and trying to convince them that it's okay, and watching people be really scared and all this stuff. It's just, anyway, it's not the most convenient option out there. It's also pretty expensive. Enoxaparin's generic, but it's still it comes in a big syringe. It requires a lot of processing to make it, so it's quite a bit more money than like plain heparin, for example. You can reverse heparin or low molecular weight heparin using a drug called protamine. What it does is it combines with the heparin or low molecular weight heparin. It forms a neutral salt that gets excreted. It takes about 5 minutes to work. 1 milligram of protamine neutralizes about 100 units of heparin. So it depends on how much you've given and how much is still in the system. You can get rebound heparin with a heparin activation or heparin effects, I should say, about 8 to 18 hours after dose, so you have to watch for that. You might have to redose them on protamine. It may cause a sudden drop in blood pressure as well, hypotension, bradycardia, and a higher than average risk of anaphylaxis-like reaction. But again, you're bleeding. It's something you kind of take with a grain of salt because this is a life-saving medication in those types of situations, and we're going to do it. All right, questions on heparin or low molecular weight heparins? Okay, warfarin. I hesitate to even say primary anymore, but it still is a really common medication, and it's probably going to be around for quite a while still. I think the newer drugs are definitely taking its place at a rapid level, but we'll talk about those and the pros and cons here in a second. But anyway, it's been the mainstay and gold standard anticoagulant and long-term oral anticoagulant for AFib and VTE for decades. I got some fun facts here. So super versions of warfarin are used as rodent poison. Sometimes people will come in and think they're really funny and be like, I'm taking that rat poison. It's like, yeah, I get it. It's not really, but yes, okay. So warfarin isn't actually used as rat poison, but some kind of things that do inhibit vitamin K processing and converting into clotting factors are used as rat poisons. Okay, so vitamin K comes from the German word for coagulation, which is coagulation with a K. There you go. Several clotting factors are derived from vitamin K. So the way that these work is they inhibit the synthesis of these clotting factors by inhibiting a couple of processes within the liver. So you have 2, 7, 9, and 10. So again, we've got our 2 and 10 that are the ones we care about the most. Again, I just said this already, but 5 to 7 days for full effect. The other thing that vitamin K produces are a couple things called protein C and S, which I don't really care you know about, but they're kind of a natural anticoagulant within the body. So when you start warfarin, you can actually decrease that C and S immediately, which decreases some of your body's ability to balance out its clotting system and have those natural anticoagulants available, which means that you could become actually hypercoagulable within the first few days of taking warfarin. So that's why it's really important to generally bridge people with something else so that they aren't clotting during that first introduction phase. It's hepatically metabolized. CYP2C9 mostly. It's highly prone to drug interactions, and drug interactions can have a really, really profound impact on warfarin. And again, we're talking about something that makes you bleed, so we do care about this as opposed to a lot of things where we're like, it'll probably be fine. This one we pay a lot more attention to. There's no renal adjustment needed with warfarin, which is a nice benefit, and probably one of the mainstays of why it'll be around for quite a while, because all the newer drugs that are replacing warfarin have renal restrictions around them. Now that might change as evidence gets done in dialysis patients and things like that, and we understand more about how we can use these drugs in patients with end-stage or late-stage kidney disease. But for now, warfarin's still the mainstay of treatment for those patients specifically. This just shows the mechanism of vitamin K oxide reductase, which is what warfarin inhibits. And that's how the liver converts vitamin K into precursors, which eventually go on to be clotting factors. Warfarin's dosed once daily, and dosing is tricky. It's one of those drugs that's still more art than science in a lot of ways. I always say a good rule of thumb is to start somebody on 5 milligrams and kind of go up and down from there, but it's difficult. It's really hard to predict warfarin. And your dose effects aren't really seen until 2 or 3 days later. So what we do is we follow something called the INR, which is International Normalized Ratio. And basically the INR is a ratio of how long it takes your blood to clot on warfarin versus somebody who's not on warfarin. And it's a standardized lab value across the country and I think the world. Well, yeah, international, right? World, you'd hope, but you never know. So you're targeting a 2 to 3. So like if assuming all of us are not anticoagulated right now, you'd go in and get your INR checked. It should be like 1 for a normal person who's, again, not on anticoagulation. Somebody who's on warfarin, you usually target 2 to 3 for most therapeutic indications. There's a couple caveats there. Prophylaxis is a little bit lower, so like maybe post-op orthopedic surgery, we used to do warfarin prophylactically. Again, that's kind of fallen out of favor now. Mechanical valves, they bump up the warfarin or the INR target a little bit to 3.5, so occasionally see that. But 95% of your patients will be 2 to 3 as your target INR. So what you do with warfarin is you start them, let's say you have a 70-kilo patient, you start them on 5 milligrams a day, they come back day 3 or 4, get their INR checked. You want to make sure it's not sky high, and if nothing's happened with their INR, get them to a higher dose. I mean, generally, common sense does kind of apply. So a younger, heavier person probably will require a little bit more warfarin. Older, smaller people will probably require less, but that's not always true. And warfarin dosing is often different throughout the week. So people might take 5 milligrams Monday, Wednesday, Friday, and 2.5 milligrams all the other days. So it gets really confusing for people. So there's a lot of clinics out there that specialize in managing warfarin. So a patient might go to a special clinic that does this. Like I did a rotation at the VA, and it wasn't my favorite rotation, but I spent 5 weeks in a warfarin clinic, literally doing nothing but warfarin dosing for 5 weeks, which again, not my favorite thing to do, but I learned a lot about warfarin. I got to talk to a lot of interesting vets too, so there's that. But yeah, it's like you have a lot of people that a lot of times this is nursing protocol driven too. So sometimes pharmacists have taken this over, like at the VA, it's all pharmacists that do the warfarin clinic. Within Alina, you might go to a clinic where there are pharmacists that manage it, or they might have, depending on the condition, like we have a pharmacist that works with our heart failure patients that manages it in them. We also have a pharmacist that does we have some pharmacists in the clinics, but most of the time it's nurses running protocols. That's fine, but it just depends on what you need and how complicated you are as a patient too. But for the most part, you're trying to keep that person in that range. And once you get somebody on a steady state dose of warfarin, it's pretty consistent. There are those people out there that might be tricky. There's this thing called lupus anticoagulant that doesn't mean you have lupus. It's this thing that happens that messes with the way your clotting factors are produced. So it makes your INR very unreliable. I remember I had this guy at the VA who would come in and his INR would be like 2 one week and 6 the next week. And he was very normal. I mean, he was a very nice guy. He'd just be like, nope, not doing anything different, still taking my medications just like you told me. Well, we should have been managing something called chromogenic factor 10. And that's a different INR equivalent lab that we can look at warfarin activity on. So if the INR is just bouncing all over the place, doesn't make any sense with the patient, consider getting a CFX on them or chromogenic factor 10. And it's just measuring their factor 10 activity directly, and that will show you how anticoagulated they are, and it should correlate to an INR. So the lower percentage of CFX is, the higher the amount of anticoagulant presence you have. So if you have 0% CFX, it means you're highly likely to bleed. A normal person would be like 100%. So again, you and I, most people in this room, probably not on an anticoagulant, and in that case, you'd probably be 90 to 100% in that range. So that's another way we can do a test, again, if the INR is just not making sense. So that's probably enough on INRs for now. Let's go to some more stuff about warfarin. As far as dosing warfarin, again, I said it's more art than science. Sometimes there are guidelines out there that recommend dosing warfarin, and they'll say to start with like 10 milligrams a day 2 times and then go down from there. I don't think anyone I know does that. I generally disagree with that as well. If you had a heavy young patient and they maybe had a history of a DVT previously and did well on a larger dose, sure. But otherwise, I still, if I had a heavier younger patient, I might go up to 7.5 milligrams as my starting dose. I probably wouldn't go to 10. The problem is if you overdo warfarin, then you end up holding it because their INR skyrockets, and you wait till it comes back down, and then you try and load them again. And it's really hard to play catch up because you're always having to look a few days into the future, and it's kind of like using a crystal ball. It's really difficult to do it. So the best thing to do with warfarin is go slow and steady. It doesn't mean you have to really go up by like tiny increments. You can be a little bit aggressive here and there. But the point is not to make really rapid changes without a good reason to do so. So my goal is always to avoid holding doses, because if you stop somebody's warfarin altogether, that's going to really ping pong them down, and then you're going to have to give them a big dose to get them back up, and it's just a big mess. So the point is to go slow and steady, try and dial in that dose as carefully as you can. And ultimately with warfarin, again, you're not looking at your daily dose. You should really be looking at like a weekly picture. So how much warfarin did they get in the last week? What average INR did that give us, and then where are we going to go from there? Adjusting that whole weekly amount and looking at the percentages you're adjusting it up and down is really how you should do warfarin, but it can be tricky. So if you ever work in a warfarin clinic or do anything like that, you'll be very familiar with this. But fortunately, when your patients are hospitalized, you just do warfarin pharmacy to dose consult, and somebody like me gets stuck with it. Or in the outpatient world, your nurses or whoever you're working with probably will do most of it. But certainly, I would imagine you guys will get called throughout your careers on different weird things where it's like, I don't know what's going on with this person's INR. Can you take a look at it? So it's good to know how to do this, I think. Okay, there's a lot of different drug interactions. I said that warfarin, we care more about it just because it is an anticoagulant. Antibiotics are something to consider. So some of them interfere with the hepatic processing of warfarin, but a lot of them wipe out GI flora, and GI flora also has to do with vitamin K absorption as well, and so that can affect, and also nutritional absorption. So if you have an antibiotic on board, you're probably not absorbing as much vitamin K to begin with, which means your body's not going to make as many clotting factors. So that's going to potentiate the effects of warfarin. You're going to see an increased INR with most antibiotics. Now, generally, we don't see a huge increase, or we don't really care. Like a 7-day course for a UTI or something like that, again, not a big deal. If they're on chronic antibiotics or something like that for something else, that might be a problem. And some of them are much worse than others, depending on what enzymes they interfere with. Amiodarone is probably the most common big one you should remember, and that's because it's used for atrial fibrillation commonly, and it has really significant drug inhibition effects, or drug enzyme inhibition effects. So you will see people's warfarin levels, or INR levels, go up on amiodarone, so their warfarin requirements will decrease over time. The problem with amiodarone is what's really weird about amiodarone? Anybody? Trivia question? Weird pharmacokinetic thing about it? How long does it last when people take it? Like 2 months, 60 days, yeah, more than that maybe. So it's got a really long half-life, which also means that it takes a while to start seeing the full effects of amiodarone. So it takes a while to build it up in the body too. So you won't see amiodarone affecting warfarin metabolism right away, but after they've been on it for a few weeks, you might see them start to, well, their INR is really increasing and you have to react. We don't usually do anything prophylactically. It's not like we'll dose reduce just to avoid that. We usually kind of wait and see what actually will happen. But that's one that it's a really common combination. There's a lot of supplements out there that interact with warfarin. I don't really have any specific ones to talk about other than like a lot of herbal supplements I'd recommend people don't take, because we'll talk about this in a separate lecture. But there's a lot of them that interfere with hepatic enzymes, especially if they're on warfarin. Some people will say like fish oil and stuff like that interferes with warfarin. Fish oil technically has some anticoagulant properties in and of itself. It's not enough to make a big deal, and I don't think it's a problem to take fish oil and warfarin together personally. And then you've got the food interactions. This is probably one of the biggest problems, in my opinion, with warfarin as a drug is there's a lot of vitamin K in very healthy food. So let's say you eat a huge salad one day and you normally don't eat salads. Well, your intake of vitamin K is probably going to be much higher than it would have been the next day or previous day. And that's going to cause a change in the way warfarin is going to manage your vitamin K, because it can only prevent the conversion of so many clotting factors from vitamin K before it gets used up. And so in this case, if you're pumping a bunch more vitamin K into the system, you're going to throw that whole thing out of whack. So the point is keeping it consistent. A huge pet peeve of mine when people tell warfarin patients not to eat anything with vitamin K in it. That's a silly recommendation. It doesn't make any sense. Just keep it consistent. So like if you decide to go binge on a kale smoothie one day, probably not a great idea. If you drink a kale smoothie every morning, that's probably not a big deal. We can work around those things and we can dose the warfarin in a way that makes sense with your daily diet, but you have to be consistent as a patient. That's my message to people. Again, just I've worked with a lot of people over time who've been like, oh, they told me never to eat spinach. And I'm like, oh, that's okay. Yeah, we want our patients to eat healthy diets too, right? So, okay. But green leafy vegetables, kale, spinach, those are kind of the big culprits I think of. There's a lot of other stuff that has vitamin K in it too. Some meats and things have it in it too. But those are like the really, really dense ones where there's a lot of bioavailable vitamin K. Other things people might do, smoking increases warfarin's metabolism. Smokers will need a little bit higher dose than the average patient. Interestingly enough, I'm not entirely sure how that works. Alcohol use, if they're chronic alcoholic and they don't have full-on cirrhosis or liver failure, their liver enzymes are going to be ramped up a little bit more than the average person, so that could increase your requirements of warfarin. And then if you're acute use, so if you go on a bender, you're basically shocking your liver into not doing anything for a little bit, and that can cause a decrease in warfarin metabolism temporarily. So those are things to keep track of too. And the reason why I'm going into so much detail about all these caveats with warfarin, again, it's an anticoagulant, and if people's INR comes in at 9, they're really likely to have a bleed. So especially if they're elderly and they fall and hit their head, that's a head bleed. That's probably pretty high mortality with that. So it is really important to keep track of this stuff and make sure patients on warfarin are aware of all these things. Okay, so can you use vitamin K to reverse warfarin? Absolutely. You can give people a bunch of vitamin K to prevent their INR. So if their INR does get a little bit high, usually the recommendation is to stop the warfarin for a little bit. If we can avoid using vitamin K, that's ideal, because if you give vitamin K into the system, then again, you're messing with variables that are difficult to control, and you can end up seeing it swing the other way. So I've seen people just get slammed with vitamin K for no real reason, and all of a sudden they have to be bridged with an Aspirin for a week because it took that long to get their warfarin back on track to make sure they have a therapeutic INR. So you can give vitamin K orally. It absorbs just fine. Usually it takes about a full day to see the full correction. So just be patient with it. Vitamin K is not a quick fix when it comes to reversing warfarin. We have a different drug we use for that. So for acute bleeding, we might give somebody vitamin K if they come in. Let's say somebody comes in with a head bleed and they're on warfarin and their INR is elevated or even therapeutic. We'll probably give them vitamin K to help with clotting. That's not going to work right away. That's to prevent clots from forming and give your body the best chance to form new clots long term. In the short term, we give a different drug, which I'll talk about here in a second. You can give vitamin K IV. There is an IV form of it. You probably get a couple hours or maybe even up to 6 hours more of a faster onset, but it's still slow. It's still not going to work right away. It takes the liver some time to use that vitamin K, and you just can't simply force vitamin K through the liver at a fast rate. That's not possible. Yeah, again, careful with the high doses. Most places have protocols around this, just like they have with other things. So they might have a dosing protocol, like I want this patient to go to surgery tomorrow, and or whatever. It's elevated. It'll say, okay, give a milligram oral before bed or something. Yeah.
Babies get this, don't they?
Yep, they do. So it's just to prevent any type of bleeding complications in the immediate postpartum phase. And so clotting factors might not be as variable newborn to newborn, and just might not be fully developed. So it's to put a bunch of vitamin K in the system so that the baby can make plenty of clotting factors on their own. Okay, moving on from warfarin. Any questions on warfarin? I'll do a little review at the end and talk about kind of like DVT treatment and stuff like that. Bring it back together. But all right, direct thrombin inhibitors. A couple drugs here. They bind to the active site of factor 2 or thrombin, inhibit fibrin formation. Their IV options on this slide are good alternatives to people who have HIT risk or have HIT already. So argatroban and bivalirudin are the two drugs here. And so usually if somebody has a contraindication to heparin, whether it be HIT or whether it be maybe a religious exemption from using the drug, that might be something that they would go to one of these agents to. So we have argatroban and bivalirudin. They're both very similarly dosed. You give and dose just like heparin. So you do a loading dose, you do an infusion, you monitor with something, usually even with argatroban, you're looking at APTT levels as well. The half-life's a little bit shorter with argatroban. It's a little bit shorter even still with bivalirudin, so there might be some advantages there if you have somebody. But I've heard anecdotally that sometimes people tend to bleed more on these drugs. But again, if you're managing it correctly, you should be pretty similar toe-to-toe with heparin. They just have different uses. And usually, again, we're looking at patients with some sort of heparin contraindication. These are both pretty expensive drugs compared to heparin, which is essentially pennies. So again, if we can use heparin, that's the preferred. These ones would be alternatives. That's all I really want you to know about those two drugs. They're pretty specialized. Dabigatran, or Pradaxa, is an oral direct thrombin inhibitor. It was the first drug on the market that challenged warfarin's spot in the echelon of oral anticoagulants. It was really warfarin was really the only option until Pradaxa came on the market. Pradaxa, I think Pradaxa might have gotten some other indications now, but at first it was only approved for AFib. They came out and they're like, hey, we have this drug that works just as well as warfarin, but you don't have to monitor anyone. You don't have to worry about drug interactions or food interactions. So therefore, everyone on warfarin should take Pradaxa. It didn't work out quite as well. They actually had a really big study with like 10,000 people in it that actually showed it was non-inferior to warfarin. However, they were comparing it to a group of patients taking warfarin who are within INR range 60% of the time. A good INR management program should have their patients within range about 90% of the time. So the question is, was that really standard of care? Within the literature, they consider it to be, but in real life, that's substandard in my opinion. Okay, anyway, so this drug doesn't have any CYP interactions. It might have some P-glycoprotein interactions, which is how like stuff gets absorbed out of the GI tract. That's a little bit more difficult to manage. Doesn't have any food interactions. Has a half-life of 12 to 14 hours, dosed twice daily. It's not reversible technically, but I should delete that because now it is. There's a drug now that can reverse it. It wasn't reversible when it came out. So what was happening is you'd get these people in like a neuro ICU like Abbott where they're bleeding into their head on Pradaxa, and there's nothing you could do about it. You can't reverse them. You let it wear off. That's all you can do. And that was problematic and causing a lot of angst amongst physicians and people who work in neuro ICUs. And the post-marketing bleeding risk kind of trickled up after this drug came out, and people got kind of scared of it just because of that. So Pradaxa wasn't a huge hit. It's still on the market now. Some people do take it, but it's definitely the least common of the warfarin challenging medications, at least in Minnesota, and what I see. Now, my dad lives in Colorado, and my dad, this is a side note, whatever. My dad is, my family has factor V Leiden, and so I have it as well. I've never had an issue with my factor V Leiden, but my dad has had multiple PEs and DVTs and stuff, and so he takes Pradaxa. But that's because he's in the Kaiser Permanente system, and that's their formulary agent. They won't prescribe the other ones, which is absolutely ridiculous, but that's what they've chosen to do. So they have some kind of a deal with the Pradaxa company, or I don't know, but it's substandard care in my opinion. Anyway, that's my soapbox. So factor Xa inhibitors are sort of the new, most common ones that you're going to see. There's a bunch of different ones on the market. I'll talk about Fondaparinux first. Fondaparinux is the oldest factor Xa. It's not oral, so kind of put this one in a separate category of what we've been talking about for a second. This is more like an enoxaparin equivalent medication. So let's say you have a patient, and I'll use a great example of, let's say, a pregnant Somali woman who came into our hospital like last week when I was working, and they didn't want to use enoxaparin because she didn't want a porcine-related product, so they used Fondaparinux in that patient. So it is, again, an option for something like that. You could use it if there's HIT risk. It's a different thing. It's not heparin related at all, so there shouldn't be any HIT risk there either. It's once daily injection. It's a little bit longer acting than a low molecular weight heparin, so it stays in the body and has a little bit slower of an onset too. But essentially think about it as a low molecular weight heparin alternative for those patients who can't take enoxaparin either for contraindications, HIT, or for exemptions that they might have personally. All right, so back to orals. Let's talk about rivaroxaban. Rivaroxaban or Xarelto was the first first factor Xa inhibitor that came out. It has the most FDA-approved indications, and the post-marketing bleeding risk for generally the factor Xa orals in general is a lot better looking than Pradaxa. In fact, it looks better than warfarin in a lot of cases. So when you make a new drug and you want to anticoagulate people, your drug has to be as good as warfarin, so non-inferior, which all these drugs have been proven. Some of them even have proven superiority in a couple subsets of populations. And you don't want to cause any more bleeding than the standard of care. So warfarin's our gold standard. These drugs need to be as good and offer some sort of added benefit. Added benefit being you don't have to go in and get your INR checked. So I didn't say this, but INR checks, the best you can get with an INR check as far as frequency is once a month. That's the best. That's the furthest apart you can do your INR checks. Now maybe some clinics go a little further than that, but it's not recommended. So once a month INRs for the rest of your life if you're on something chronically. These drugs don't have that. There are some drug interactions, which we'll talk about here in a second. And the big thing is that rivaroxaban requires renal dosing. So for patients who have good kidney function, though, it's a no-brainer to put them on one of these over warfarin, in my opinion, especially for like a DVT or a PE. The other medications that are on the market right now are apixaban and edoxaban. There might be another one too, but I haven't seen it used. Edoxaban's not commonly used. I'd say apixaban and rivaroxaban are the two ones that are really big right now. I think a lot of people are even leaning more towards apixaban. It maybe has some more favorable safety profile based on clinical trials where it doesn't cause quite as much bleeding as warfarin or rivaroxaban. So I think we'll see more head-to-heads against these things in the future, and maybe one will come out as preferred in certain areas. But right now, they're all getting used quite frequently. And at first, the problem was a few years ago when they first all came out, they all kind of hit the market at once, and they're expensive compared to warfarin, which has been around a while. It's relatively cheap. And people were saying, well, even with the lab values or the lab monitoring costs associated with warfarin, it's still a lot more expensive to give one of these drugs than to send somebody in the clinic once a month for INR. So insurance is like, well, we're just going to keep paying for warfarin. Slowly, insurances are coming around, and most of them now cover factor Xa inhibitors with no issue whatsoever. So that's good for our patients because they're definitely more convenient for most people. And there are a reversal agent available. So let's talk about these in a little bit more detail just because it's a huge area of medicine right now, and that'll be kind of the end of our lecture. I've got a bunch of tables and stuff that I stole from a colleague of mine that I'm not going to test you on. It's just more reference stuff, comparison things. So target-specific oral anticoagulants. You'll hear the new drugs. So either this would be, dabigatran, rivaroxaban, edoxaban, and apixaban. So the 3 factor Xas plus Pradaxa are all kind of thrown into this group. And they're either called DOACs or NOACs or SOACs or whatever you want to call them. I don't really care. They're called target specific because they work directly on factor Xa. They don't go through this roundabout mechanism through the liver like warfarin does. That's why they're called that. Again, they haven't really been proven to be better than warfarin, but they don't really need to be because we know warfarin is a really good drug. It reduces risk of stroke in AFib patients substantially. It reduces risk of recurrent DVTs and PEs substantially as well. It does its job, and that's what we need it to do. No dietary restrictions. In your ideal patient for a DOAC would be a non-elderly, good kidney function, relatively normal weight, or possibly somebody with poor access to lab facilities. Maybe they live kind of in the middle of nowhere, and getting someplace once a month where they can get INR checked is not an option for them. Lack of reversal agents is no longer a major barrier. I should have updated that, sorry. There are some in development, and the factor Xa one just got approved recently, finally. So that's why I thought I changed that. Oh, well, anyway, we've got the slide on it here in a second, so I'll talk about it. But yeah, there is a reversal agent, and that was one of the big problems with these drugs when they first came out is like, I don't want to prescribe it because there's nothing I can do to reverse it. And that actually wasn't true because we can use the same drug we use to reverse warfarin in acute settings, and I'll talk about that here in a minute. But overall, good drugs, no monitoring. Some people might say that, well, we should monitor something here so we know how well it's working, and the kinetics are predictable. So when you give warfarin, you don't know how that warfarin is going to affect that individual person's vitamin K clotting factor pathway specifically. You know how these drugs are getting metabolized. They're target specific. They're going to work the same way basically in every patient we give them to, with some variances here and there. But for the most part, they're pretty consistent, which is a big benefit over our standard of care. And then, of course, the cost is something to consider as well. All right, sorry, there's a bunch of animations on this that I didn't delete. So standard dosing for approved indications, just in case you want to compare how they're dosed for the different indications there. This is probably the most important slide, I think, just from practical information. You have the time to therapeutic maximum. So again, these are relatively fast onset, a couple hours for some of them. You don't need to bridge these patients. So if you want to start somebody, let's say somebody comes into your emergency department with their golf ball swelling, leg pain, textbook DVT, and they're fine, healthy otherwise, start them on one of these, send them home. You don't have to bridge them with Lovenox. You don't have to get them warfarin, set up follow-up lab monitoring. It's super convenient for a relatively healthy person, which is why these have become really popular. Half-life. You see the half-life is about the same. The interesting thing is rivaroxaban is a once-daily medication when in fact it has like one of the shortest half-lives out of all of them. Why? I'm not entirely sure. I think that its effects on the factor Xa probably go beyond its actual half-life in the body is my interpretation of that. But the other ones, well, edoxaban's once daily, but some of apixaban and dabigatran are twice daily. So again, they chose different pathways with it. But certainly convenience aspect, rivaroxaban and edoxaban would have a little bit of an advantage there. Again, no routine monitoring for our new drugs. You can monitor like anti-factor Xa levels potentially, but you'd have to have a lab that's calibrated to understand how the drug works specifically in that person's blood, which isn't going to be a common thing you're going to see. So basically, it's not super if you got a factor 10A level without calibrating your machine properly, you wouldn't really get a useful value, is what I'm trying to say there. And then, of course, the renal adjustment. So that's one big take-home point. Warfarin doesn't need renal adjustment. That's a nice advantage to using it still versus the new drugs. There's some interesting stuff there with or without food. Rivaroxaban, generally with food, it has some issues with absorption if you take it on an empty stomach. Pregnancy category. Warfarin is category X. It's contraindicated in pregnancy. Heparin products are okay in pregnancy. The new drugs, we don't really know. They haven't really been studied. Apixaban actually has a category B, which I think they've had some animal models that have been promising, but none of them have come out and actually done a study in a pregnant population, which is ethically has a lot of issues with it, right? So we may never get there. I don't know if any study will ever be designed to take that on, just because of ethical reasons why we don't test drugs in pregnant patients. But and there's alternatives, right? So it would be one thing if there was nothing else we could give